Thank you very much. So I start with a clinical scenario that's near and dear to our hearts and that we are all familiar with, and this is the appearance of joint pains in hemophilia clinic, and the pointed question here, which joint is bleeding? And this poses a clinical dilemma because signs and symptoms are really non-specific. Warmth, swelling, range of motion deficits can be found in a broad spectrum of other arthritic conditions. So let's stick with the knee for a moment and ask ourselves about all the many structural abnormalities that can actually contribute to pains outside of bleeding. Well, we start with tendons and ligaments here. They move our joints. And then we have the synovial lining here in red. It's just a 1 to 3 cell layer in non-pathological states that contains a lot of vessels, which affords vascular perfusion and thereby nutrition to the joint space and to the cartilage. It's also believed that bleeding originates from there, especially in childhood, but we don't know for sure. And the remainder of the structures are really here to provide cushion, friction protection, and shock absorption. So we can start here with the joint space and its fluid in the recesses. Then we have cartilage lining the bone here, and menisci that are made out of glycosamine glycans. These are complex sugars and collagens, again, all for shock absorption. And then we have fat pads, something we always forget to mention, suprapatellar, prefemoral, and here the Hoffa's fat pad. And all of those structures can swell, can proliferate after bleeding, and can get impinged, inflamed, and be painful. And finally, we have the bursa here. These are just slivers of fluid-filled pockets. Compare them to an airbag. They only blow up upon collision. So the gold standard for joint pathology is not imaging, it's actually arthroscopy and histology. Now, we cannot do that on every patient all the time, and this is why we invented imaging. But imaging, no matter which imaging, is a surrogate method. It increases the accuracy of our clinical diagnoses, it lacks invasiveness and surgical risks, but the sensitivity and specificity of any kind of imaging is only 70 to 90% of acute soft tissue joint pathology. So lots will be going on that we might be never able to really ascertain, even with the finest imaging modalities. And so, for example, MUSCUS, this is short for musculoskeletal ultrasound, or MRI have been shown equally good for specific conditions such as a rotator cuff tear in the shoulder. So pain in arthropathic joints, I think, really deserves improved diagnosis and management, just looking at these 6 case scenarios that are all quite different. So in hemophilia clinic, what interests us most is obviously, is blood present? Does bleeding contribute to pain? Which imaging study should we do? And then what are the therapeutic options? I think many of us agree that clinical exam and patient perception might not be quite as accurate as we think. And so what imaging modalities do we have available? I'm going through them one by one. So we have X-rays. Those are not sensitive to soft tissue changes, fluid, or bleeding. We have CT scans. They might, but they provide contrast and quite a bit of radiation, so we won't do that frequently. And then we have the MRI, which is a long exam, costly, and actually difficult to distinguish blood from non-bloody effusions. And we come to that in a little bit. Just hold that thought. And here is where musculoskeletal ultrasound, in short MUSCUS, with the power Doppler function, in short PD, comes in handy. Power Doppler with ultrasound is a function that allows to assess the extent of abnormal microvascular flow in intra-articular tissues. So let's go to the two most pertinent modalities here, and this is the MRI and below the ultrasound. So the MRI works quite different from ultrasound. Physics here are that magnetic properties of protons in water are utilized to generate an external magnetic field and thereby create an image. Vascularity assessments and the assessment of synovitis requires intravenous contrast. Ultrasound works differently. It uses echo from reflected sound waves, and that's done in frequency, hertz, for tissue penetration and resolution. And vascularity just requires this power Doppler function, no contrast needed. What is sometimes a little underappreciated is that ultrasound has a spatial resolution that is 10 to 15-fold higher than the MRI. It's really like zooming with a microscope into certain spaces. So focus in hemophilia in terms of point-of-care imaging in clinic. Again, what interests us most here is probably finding out about the presence of effusions, bleeding, and or inflammation. And so let us take an example from my clinic to show you what an MRI versus an ultrasound can do in a pertinent question. This is a 54-year-old male with moderate hemophilia A and persistent knee pain after a fall. 1 to 2 weeks into this injury and an appropriate length of clotting factor treatment, that pain would just persist. And my first question would be, is an effusion present? And if an effusion is present, is there maybe still blood lingering in the joint that could cause the pain? So we did an MRI and an ultrasound on the same day and depicted here our MRI T2 fluid-sensitive sequences. And the findings here are quite some signal abnormality or signal intensity in the suprapatellar bursa. Now, the question comes, is this an effusion or synovitis? Without contrast, that will radiologists won't be able to tell that apart, and it's really dependent on the clinical context. And then secondary, is the effusion bloody or non-bloody? Also something that cannot be distinguished on MRI. Then, obviously, we have a number in this MRI, a number of other chronic changes, such as synovial hypertrophy, cartilage destruction, and marrow edema. They are all important findings, but for our point-of-care focus of the day, they might not be important. So, hang on. Go back one. No, how do I go back? Can we go back? Yep. Back. Yep, thank you. So, now we come to the musculoskeletal ultrasound of the day, and what it shows us is unequivocally a hypoechoic compressible fluid pocket in this same area with complex displaceable materials. So this is an effusion and has most likely still blood products in it. So why is it that I say with such confidence that conventional MRI cannot reliably detect blood products? Well, that was here a very simple experiment that I did with my radiology collaborator in the MRI lab. So we took joint fluid and admixed it with increasing concentrations of blood and then MRI'd this. And so on the left, you see the T2 sequences with 0% blood and 100% blood and a lot of concentrations in between, and the signal intensity is just the same. These are the fluid-intense sequences. Now, if we go to more tissue-intense sequences, T1 weighted, you might see a difference between 0% and 100%, but it's not clinically relevant because no one has 100% blood in his joints or her joints. And so these little grades of shades of gray in the middle are really not diagnostic because they don't allow tissue discrimination from the rest of structures imaged on MRI. So now we come again back to the ultrasound. How would one distinguish bloody versus non-bloody effusions? And we take the lateral recess here as an example. Both are compressible with the transducer, and then bloody is usually hypoechoic with displaceable materials or speckles, versus non-bloody, we call that a simple effusion, is simply anechoic and black. And I have 3 effusions here for you, and we can go through them. This would be a very fresh bloody effusion. We call it acute complex, hypoechoic, milky, with displaceable speckles upon compression not shown here, versus here below would be the other end of the spectrum, a simple anechoic effusion, all black. There is no displaceable material here, and disregard this, these are just tissue fronds. And then we have something here like a subacute complex effusion. It's hypoechoic with materials. This is a bloody effusion that's several days old. It starts to coagulate. It's only semi-compressible and has all kinds of fibrin strands and coagulating material in there. So the ultrasound can also give you additional inflammation or additional information about the extent of abnormal vascularity in soft tissue associated with problem or target joints or with bleeding. And this is the power Doppler function, and I show examples of 3 patients here for you in the lateral knee, in the subtalar joint, and in the elbow. This gentleman has severe hemophilia B, and he had knee replacement 2 years earlier. This patient is 53 years old, and this was in his subtalar joint 2 weeks after an ankle bleed. And this is a patient, 25-year-old, with an elbow that shows chronic subclinical blood products, meaning blood in the elbow without pronounced pain. And so you can see on the power Doppler all these various extents of inflammation and of vascular findings compared to the contralateral joint in each of these patients without such vascularity. Now, why is that important? Because hemarthrosis is associated with vascular remodeling. And you see here 10 patients presenting at baseline with somewhat abnormal pain scores, but not too bad, and then having excruciating pain, presenting with proven bleeding episodes. And during these proven bleeding episodes, you can see that the power Doppler signal that's already somewhat abnormal at baseline is increasing dramatically, depicted here in this example in the ankle. Now, this is important since this vascular remodeling seems to be associated with bleeding and can persist quite a long time. And this is a study from Spain where a Spanish physician followed his patients with ultrasound after bleeding episodes and could see that half of those 10 patients still had blood lingering 1 week later and also had synovitis. He called that synovitis at the time, synovitis present with findings similar to that. And that, in turn, might be important because it could be or is associated with rebleeding tendencies shown in the elbow joint of this gentleman with severe hemophilia A after liver transplantation and normalized factor VIII levels. He had intractable bleeding into his elbow. In the angiogram here, you can see the blushing and extravasation of contrast material, and the abnormal vascularity is shown here in the power Doppler, and this bleeding could only be ablated with embolization, here clearing the elbow and the vascular signals. So that just opens up a whole new realm of thinking in terms of new anti-angiogenic and maybe anti-inflammatory treatments beyond just clotting factor replacement. So now that you know what the ultrasound can do for you, it's important to realize that diagnostic ultrasound is emerging rapidly in many other disciplines. And this is just an opinion piece from the New England Journal of Medicine 2 years ago, demonstrating that medical students trained on those little pocket ultrasounds outperformed cardiologists and internists' exams. And so these modalities are currently introduced into medical education. And you see, we have come a long way from MRIs to laptop ultrasounds and now to pocket-held devices, and I want you to hold that thought to the end. So ultrasound or point-of-care ultrasound in hemophilia clinic just fulfills or has to fulfill the same standards as any other point-of-care diagnostic modality. So how to deploy it best is for a well-defined purpose and a focused question. It will not replace a full joint exam. It's quick, easy, recognizable findings. These findings need to be learned easily, and they should be performed at the bedside or in clinic. If you have to send your patients for any test, not just imaging, to the lab, to a radiology department across the street, and you have to wait for the test results for several days, it's not a point-of-care test. So the advantage of point-of-care ultrasound are that it's fast time to assessment, speed of examination, there is no contrast, sedation, or claustrophobia, maybe like with MRI. There is no pain with fixed positioning over a long period of time. It's cheap, and it has high imaging quality for soft tissues, fluid vascularity, and also osteochondral changes. And I see that with some certainty, and we'll just make a little excursion for one slide in work that we are currently doing. So this is a osteochondral evaluation comparing high-resolution ultrasound with MRIs. And what you can see here in this patient with really early stages of arthropathy, looking into the femoral trochlea. So you can see the femoral outline here. And you can see that it's a little bit defective. And this is not picked up on usual conventional MRI, where this osteochondral line is just depicted as a normal black line, but it is picked up on so-called UTE sequences. These are research sequences. Now this line is white, and you can see that it's somewhat broken and irregular, confirming what's visible here on the ultrasound. Also, you can see how easily cartilage measurements are feasible. They are not so easy doable on MRI, where the beam is not perpendicular to the cartilage and where one is subject to slice size. And so the ultrasound really allows the recognition of a wide spectrum of osteochondral abnormalities here with cartilage wear, erosions, and osteophytes, here again depicted in this ultrasound of someone with severe advanced arthropathy and bony erosions and clefts. And here also visible on ultrasound, but you learn to appreciate that the outline of that osteochondral surface is really precise on ultrasound and somewhat blurry on MRI. So with that, we come back again to our point-of-care ultrasound for management of pains. And what I like to use it best in my clinic is truly for acute and chronic joint pains. For a simple question, helping the patient and myself to answer, is there an effusion? Yes, no. Is there hemarthrosis? Yes, no. Is there hypervascularity? Yes, no. Are there something like tendon sprains or maybe some other advanced diseases that we can diagnose? Yes, no. And I also like to use it for muscus-guided intra-articular needle placement for aspiration and injection, and we will talk a little bit about that. So the data behind this, all of this, are truly that patient and physician perceived pain etiology has been shown to be correct in only about a third of painful episodes. And again, symptoms and findings are so similar whether there is bleeding or not, and did not permit the distinction. And so this leads to factor activity levels at the time of ultrasound, at least in this study, that showed substantial overtreatment in patients who actually didn't have bleeding, or under treatment in those patients who had bleeding. And that's somewhat concerning because we are missing out on a whole spectrum of many other conditions that were also shown on the ultrasound that probably contribute to pain and that are actually treatable and in other musculoskeletal disciplines would be treated, such as synovitis, fat pad inflammation, tendinosis, tendinitis, and so on. And so it shows the dichotomy that we are sort of torn. Bleeding, yes, no. Clotting factor, yes, no. Sort of is the only spectrum we consider. But I think we have to open ourselves a little bit to all of these conditions and their treatments. So in this study, ultrasound was really critical to guide treatment decisions, and with clotting factor adjustments, physical therapy, anti-inflammatories, and intra-articular injections, this directed therapy improved symptoms in many patients. And now I would like to spend 1.5 slides on intra-articular injections. Those have fallen out of favor maybe 20 or 30 years ago in hemophilic or for chronic pains in hemophilic arthropathy, although they are frequently utilized in osteoarthritis and rheumatoid arthritis and are effective there. And this is maybe because people feel a little uncertain about sticking needles into complicated hemophilic joints. But with the ultrasound, needle placement now is safe, atraumatic, and it's easy to visualize where the needle track is. So you see here in the ankle joint, see the needle coming right into underneath the capsule, into the fat pad, does not have to place necessarily into the tibiotalar space here. Suffices if it goes under the capsule. And the power Doppler will show you vessel localization, and therefore you can slide the needle easily by those vessels. And this is just an example affording here an aspiration of a really complex large effusion that provided pain relief. And so these steroid injections are efficacious in hemophilic arthropathy, which has finished a case series of about 45 patients. And you can see that the extent of pain relief with corticosteroid injection was quite significant. And most patients, not all, but most, would have pain relief more than 4 weeks, some out to 6 months. And another good thing is the reduction of vascularity in response to steroids, shown here in a knee and an elbow before and after injection. So now we'll just go together through 3 cases illustrating point-of-care ultrasound for evaluation of painful hemophilic joints. All 3 cases have been my patients. So case 1 is a 23-year-old with severe hemophilia B. He has, unfortunately, a history of non-adherence and denial. He truly believes that all of his pain are arthritic. He really does not like to infuse himself. And so this is his baseline scan. It's the tip-tail joint space here, really nice and narrow, and then above you have fat pad and extensor tendons. And then upon presentation and bleeding, you see this joint space widens. It has complex compressible material in it, here in Sachs axis and here longitudinally. And if the power Doppler is turned on, you just see the arteria dorsalis pedis. There is no inflammatory signal at the time. And so he was clearly bleeding and treated him with 3 days of clotting factor and then reinstituted prophylaxis. And simply the engagement in front of the monitor and discussing all of this with him, I think, helped for improved adherence. And I also would like to point out to you, this is him on presentation. He had pain and some range of motion deficits, but just looking at those ankles, I don't think you could tell which one is bleeding. There was no warmth and there was no swelling. Case 2 is a 23-year-old younger man with severe hemophilia A, and he's also autistic. So he presents with his mom and ankle swelling, and the little I could glean from the interview, possibly suspected inversion injury, an ankle sprain. So we applied the transducer position that's necessary to diagnose ankle sprains, and what you can see here is that the anterior tibiofibular ligament is sort of partially torn off the talus, and as soon as power Doppler was utilized, you can see that there's a lot of inflammation in this area. So that patient has a partial ATFL sprain, an effusion, visible here, probably complex, and inflammation. So that helped treatment decisions. We obviously subjected him to factor VIII infusions, but then he also got x-rays, an orthopedic consult to look for other possible fractures that can be associated with this type of injury. And then we decided to do conservative management, mostly physical therapy appropriate for this type of injury. And case 3 will illustrate you how you can use the ultrasound to follow your patients after bleeding episodes. So he's 36 and has severe hemophilia A, and he comes with a spontaneous elbow pain that he knew was already a joint bleed, but we verified it with the ultrasound. Oops. Can we go back again? Thank you. Verified this with the ultrasound, and we have his baseline scan of a problem elbow joint on file, and you see here the radial head and the humerus. This is what it should look like under normal circumstances, with a small effusion already present at baseline. But then upon presentation, you can see the distension of the capsule here over the anterior joint space. It's filled with complex bloody material. And then 5 days later, his pain was gone on day 2 after 2 infusions with factor VIII. But 5 days later, despite the fact that pain is gone, this bleed is still lingering. It's not resolved yet. And so this is just, we imaged him 2 months later, demonstrating that we really don't understand how long blood remains in the joint and why it is that factor seems to ablate pains after 1 or 2 days. Pain is gone, but bleed remains. So lots of work to be done here too. And now we fly a bit into the future. It's a new project that we are exploring at our clinic, and it's pocket tele-ultrasound to answer one simple question, bleeding or not. And my personal vision is that this could be patient-performed at home, in the office, or in school, or by allied healthcare professionals, maybe at centers, or even in remote clinics of resource-restricted countries. And so you see me here with several of my patients, and we are trying this out on their joints in relation to their problems and transducer positions that can catch certain issues. And the feedback is overwhelmingly positive, and it seems that patients are really eager, and it's easy to learn. And so now we are currently comparing conventional ultrasound and the images obtained with those pocket devices. And here we will have images with the handheld pocket, and then with the portable ultrasound, and then finally the stationary device. And even if your eye is not trained to ultrasound yet, I think you can appreciate that the images here pertaining to effusion, yes, no, are quite similar. So more to come on that front. So in conclusion, MOSCAS is a valuable tool to determine joint and soft tissue bleeding for targeted hemophilia management. MOSCAS improves our diagnostic accuracy for musculoskeletal conditions beyond the physical exam, and we should use it like so many other musculoskeletal disciplines. It empowers patients to participate in their care, and it opens new avenues to elucidate the origins of bleeding and the development of hemophilic arthropathy. So with that, embrace the evolution of medicine, and thank you for your attention. Think back to 200 years earlier, we just looked at patients, then at some point we started to palpate, and now we are sending them home with pocket ultrasounds. I would like to acknowledge many people. Ultrasound does not happen in a vacuum. First and foremost, our patients, then my imaging collaborators and specialists, Dr. Eric Chang in radiology, and Randy Moore, he's a musculoskeletal ultrasonographer, and my whole HTC team. First and foremost, Monica Diaz, because she really organizes our ultrasound program. And my funding sources, those who support this effort, Pfizer, Biogen, the National Hemophilia Foundation, and our Novo Nordisk, and our HRSA service grant. Thank you again.